So as Anwin said, my role in treating patients is involved in early phase clinical trials, that's experimental drug trials. And also I treat patients with gynecological cancers, and I tend to merge the two in terms of looking at trying to develop new drugs for gynecological cancers. I apologise because I need to look at these slides because they're not in front of me. I will try not to ignore this side of the room, but I tend to look over towards the right. So if the pointer works, yeah. So I just have the following disclosures, which is my involvement with obviously pharmaceutical industry in terms of developing new drugs, which is quite standard for a phase 1 doctor. And Newcastle University, who's my employer, actually receives royalties for the development of rucaparib, but I don't personally benefit from those. So this is what I was asked to cover. And this is a huge challenge, really, to talk about this in 20 minutes. It's a huge challenge to talk about this to an audience that know and are involved in the development of these things. So I hope I've pitched this right, and I'd welcome any feedback and questions during the break if I haven't clarified things appropriately. If I've done my job right, you hopefully won't be bewildered, confused or lost. But again, I can signpost you in the breaks. So what are PARP inhibitors? And how do they work? And patients do ask me this now all the time as we're starting to prescribe drugs like niraparib. And a patient of mine asked me this on Monday in the middle of a busy clinic. And after I'd finished explaining it to her, she did say, "We won't discuss that again. I'll take your word for it." So PARP inhibitors basically block the action of something called PARP. And PARP stands for poly-ADP ribose polymerase, which is why obviously as doctors, we like to keep things simple for ourselves and we call it PARP. There are actually 17 PARP enzymes in our bodies, and most of the time when we're talking about PARP or PARP inhibitors, we're talking about PARP1, which is the first one. PARP inhibitors work in a process in our bodies as to how we repair damaged DNA or damaged genetic material, and that process is known as base excision repair or single strand break repair, which is basically the type of damage it's trying to repair. If you have this DNA damage, it can happen as things that happen to you, so things like radiotherapy, chemotherapy can cause DNA damage, but it can also happen just as things that are going on as normal day-to-day in our cells. So our cells, just by the fact that they're working, cause damage which needs to be repaired. Now this is a cartoon of the pathway, and again, you don't need to know much about this, but basically, I don't know if the pointer works, I don't know if you can see that, but the damage is happening at the top, and it causes a single strand break. And part 1 is pivotal to the repair of that break, and it comes in and it attracts some of the players in this process, and the single strand break is repaired. So part 1 is a good thing. It's involved in repairing DNA damage. So you might sort of start asking, well, why are researchers trying to develop a drug which obviously blocks something which repairs DNA damage? Because repairing DNA damage is obviously a good thing. And the answer to this lies in the real sort of original development of PARP inhibitors. So PARP inhibitors were never intended to be used as drugs on their own. They were basically developed to try and improve the effectiveness of other drugs which cause DNA damage, such as chemotherapy or perhaps radiotherapy. And this picture here hopes to sort of describe this. So the swirly grey lines is our DNA. And if you give chemotherapy or radiotherapy to a patient, ultimately you're going to damage the DNA. Now the cancer is very good at repairing this damage, and it relies very heavily on these sort of repair pathways. And so it can just repair the damage and the cancer cell can survive. So that's not a good thing. So if you inhibit your part 1 with a PARP inhibitor, you're going to stop that damage being repaired and the cancer cell will die. And that's where PARP inhibitors were originally developed, as kind of to be used in combination with chemotherapy or perhaps radiotherapy to try and improve the cancer kill of these existing drugs. And this is where the sort of development of PARP inhibitors sort of started, on this bottom hand side, on the right hand side here, to try and improve the delivery of radiotherapy or chemotherapy. Now in 2005, we changed that development. And what was going on before 2005 or during this sort of time was lots and lots of early phase clinical trials looking at PARP inhibitors plus chemotherapy. And I was involved in many of these trials. And what we found, if we tried to give a PARP inhibitor at the same time as chemotherapy, yes, we might kill more cancer cells, but we actually also damage more of the patient's normal tissue. So women and men who were on these trials got lots of low blood counts, lots of problems with side effects. So the combination of PARP and chemotherapy at the same time has not really yielded very promising results in clinical trials. What's been more promising is combining PARP inhibitors with radiotherapy. And again, this isn't really the focus of my talk, but there are many ongoing trials looking at PARP inhibitors, combining them with radiotherapy, mainly in other cancers, so not ovarian cancer. So in 2005, the development of these drugs took a sort of completely different turn. And it was a turn to try and develop them as single agents to try and exploit differences in cancer cells. And I'm going to hopefully explain some of this to you today. And this is sort of really where the role of PARP inhibitors in ovarian cancer took off, and it's really known as the PARP-BRCA story. So in 2005, there were 2 research papers published in the journal Nature by 2 independent research groups. One was Newcastle-based and the other was London-based. So the whole story really of PARP inhibitors, even though it's a global phenomenon, it really started out in the UK with UK scientists. And what these researchers discovered was that if you took cells in a laboratory, in a dish, or perhaps animal models, and you gave them the PARP inhibitor on its own, if those cells had a faulty BRCA gene or they didn't have the BRCA gene present, they were very, very, very sensitive, which were about 1,000 times more sensitive to the effects of the PARP inhibitor, and were killed. And that was much more than the cells that had the BRCA present or the BRCA was functioning normally. And the PARP inhibitors at the time that they were using were early versions of the drug rucaparib and olaparib that we now know as Rubraca or Lynparza. So why was this? And everybody at the time, there were some theories proposed. And the main theory, which is really borne out through further experiments and research, is known as this concept of synthetic lethality, which some of you may or may not have heard of. Now, this figure looks quite complicated, but again, I'm going to go through it. So the black swirly lines at the top are your DNA. And as I've already said, just by sitting here, living life, your cells get damaged. So they cause their own internal damage. So you get this break called a single strand break, and you need this pathway which PARP is involved in to repair it. If you block that pathway with a drug, i.e. a PARP inhibitor, then this damage persists and it isn't repaired. So you've got this single strand break that carries on in the cell. Now it needs to be sorted out because the cells can't function if you don't repair the DNA. If it's not sorted out because you've got a PARP inhibitor, then this break becomes what's known as a double strand break. And that's much more serious for your DNA, and your cells can't really cope with that. And if it is left unrepaired, those cells will die. Now, the pathway involved in repairing double strand breaks is known as homologous recombination, or HR, that's what I'm going to call it. And if you have a deficiency in a BRCA gene, then that pathway doesn't work properly. So if you use a PARP inhibitor in the setting where you've got a BRCA deficiency or a deficiency in this HR pathway, then it's going to result in the death of the cell. And this is what was seen in these early experiments. So the cancer cells, or the cells without the BRCA died, and the cells that did have the BRCA functioning, they survived. So what's all this got to do with ovarian cancer? Well, many of you in the audience may know, because you may already have been told you've got a BRCA mutation, but we know now that about half of all high-grade serous ovarian cancer, which is the most common type of ovarian cancer. So when we talk about ovarian cancer, as Richard's already said, it doesn't apply to everybody. This is specifically talking about patients with high-grade ovarian cancer, and particularly high-grade serous ovarian cancer. But that makes up the majority of ovarian cancer cases. So about half of ovarian cancers have deficiencies in this pathway homologous recombination. And the most common way of getting that deficiency is by having a BRCA mutation. Now, BRCA mutations there are thousands and thousands of BRCA mutations within the BRCA1 and BRCA2 genes, but they're classified into being germline or somatic. And again, many of you may already know what this means, but just to go over it, germline mutations are ones that you inherit and that you can pass on, obviously, to your children. And we know now that they occur in about 15 to 20 in every 100 women with ovarian cancer. Somatic mutations are mutations that just occur in the cancer, so you haven't inherited it and you can't pass it on, and it just happens spontaneously in your cancer. And that's much less common, and it's only up to about 4% of women. So if we take all ovarian cancer women, it's probably about 1 in 5 that might be affected by having a BRCA mutation. And I just want to quickly highlight this today, but BRCA testing in ovarian cancer should now be standard of care. So myself and other medical oncologists do this as part of our own routine oncology clinics. In some centres, you may be referred to a geneticist to have a BRCA test done. But I think all women with a high-grade serous ovarian cancer should be offered BRCA testing, and that should be done at some point in your treatment. I tend to do it at diagnosis of my patients when they're having the first line of treatment. Other centres will do it if the cancer's come back. But if you're not sure about it, I strongly urge you to ask your own oncologist about having a BRCA test done, or your nurse specialist. And obviously I'm happy to talk to people about that today as well. It should now be available all throughout the whole of the country that you can have a BRCA test because you've got ovarian cancer. So back to the story of PARP inhibitors and BRCA. And Richard mentioned that I was probably going to talk to you about a 20 to 30 year pathway of drug development. Well, really for PARP inhibitors, it was actually 53 years of research before we got a drug approved for use from having the sort of initial drug discovery. And this sort of timeline sort of takes you through it here. And the books there are supposed to represent the many, many PhDs, including my own, that were done on this subject over all of this time. You'll be pleased to know it's not available to be read at the back afterwards. So 1963 is when we had the discovery of the first PARP enzyme, so PARP 1. And then 1980, we had the first PARP inhibitor. And this is a drug that isn't a drug now that's used in patients, but it was based on the original PARP inhibitor, which was actually rucaparib. In the 90s, we had the discovery of the BRCA1 and 2 genes. So before this date, we didn't even know about them, and we didn't even know about the sort of hereditary breast and ovarian cancers that come with those. In 2003, the first patient in the world received the first PARP inhibitor, and that was in combination with a drug called temozolomide, and that happened in Newcastle, and I was one of the people privileged to be involved in those trials. In 2005, we had this BRCA story emerging, that PARP inhibitors perhaps should move away from being combined with chemotherapy and should probably be used on their own and potentially in patients or women with BRCA mutations. This then went into clinical trials, and we had the first real exciting data about olaparib, which is a PARP inhibitor also known as Lynparza, showing that, yes, people with BRCA mutations, with breast cancer and ovarian cancer, would respond to single-agent olaparib, and that was in 2009, 2010. And then in 2012, we had a study showing the benefit of maintenance olaparib, so that's having treatment after response to chemotherapy, and that was known as Study 19. And then we got to the end of 2014, I think it was December 2014, where the FDA and subsequently the EMA approved olaparib in the management of ovarian cancer. Now, the FDA is the Federal Drug Agency, so that covers America, and the EMA is the European Medicines Agency. So for us to be able to use a drug, we need the EMA to approve a drug, and then obviously subsequently it may go through the funding streams, which would be nice. But the original license of olaparib was to be used in women whose cancer had come back. So this is not for patients at the beginning of their treatment, and they'd had a course of chemotherapy which was platinum-based, so carboplatin or sometimes cisplatin. They'd had a very good response to that treatment, and it was as a maintenance treatment. And it had to be after so many lines of treatment, and it had to be in patients who had a BRCA mutation, so either a germline mutation, so one that you've inherited, or a somatic mutation, which is just found in the cancer. Now, if we fast forward to 2016, so this is also gives you an idea of drug development and how drugs go through systems and approvals. So although the FDA and the EMA had approved olaparib, we couldn't actually give it to the NHS until 2016. Now, NICE, which covers NHS England and also sends directives to Wales and I think Northern Ireland when they do full approvals, made this drug available through the NHS. It was a very restricted license, and it had to be given to women who were in their third line of chemotherapy, and obviously, again, those that only had a BRCA mutation. And the SMC in Scotland also approved olaparib for the same group of patients, but it wasn't restricted to the line of treatment. So if we look from there now, what's happened over all of that time? So there's been so many trials of PARP inhibitors that I just couldn't possibly tell you about them all in the time frame. But if we sort of look at what questions have these trials tried to answer in ovarian cancer over the last few years, and these are the sort of three questions that probably we've been trying to look at. So one is, should PARP inhibitors be given as a maintenance treatment, which is the top schedule here, where you've got the blue lines represent your chemotherapy, you have a response to chemotherapy, and maintenance is trying to maintain that response. And what you're trying to assess is, can you delay the cancer growing or the need for another treatment? And the delay in cancer growth is what we call progression-free survival. Or should we give PARP inhibitors as drugs themselves without chemotherapy? So should we say to a woman, you've got your cancer, it's come back, why don't we give you a PARP inhibitor rather than chemotherapy? So these are the strategies that have been looked at. Progression-free survival is what we define in trials as this controlling of the cancer, which is what Richard was talking about for the Desktop 3 trial. The information from that study looks at progression-free survival. So the other strategy we've looked at in these trials is, should we restrict PARP inhibitors to BRCA-mutated ovarian cancer, or should we go up to the patients and the women that don't have BRCA-mutated cancers, or maybe have defaults in other DNA damage repair pathways? And if we do that, how can we identify other patients? Because we know that BRCA mutations are easy to test for. What about these other patients? And the other question that we've looked at in lots of trials is, should we restrict PARP inhibitors to patients whose cancer is still perceived to be sensitive to the platinum drugs? Or what about those women who have platinum-resistant disease, which is much more difficult to treat and is a much bigger area of unmet need in oncology? So if we go from 2016 to 2018, We've got the results of 4 really big clinical trials. I'm just going to try and talk to you a little bit about them, but not in lots of detail. So we've got the ARIEL 2 trial, SOLO 2, ARIEL 3, and the NOVA trial. So the ARIEL 2 trial looks at rucaparib, which is the PARP inhibitor I was saying was developed through Newcastle University. And it was open to women who have BRCA-mutated ovarian cancer and not known to have BRCA mutations or known to be a what's called wild type, so they don't have a mutation. So you could be untested or tested, and you could go into this trial if you did or didn't have a BRCA mutation. You basically had the treatment as a chemotherapy sparing regime. So you were offered chemotherapy as standard of care, but you were offered rucaparib as part of the trial. And the success of the drug was going to be measured by this measurement called progression-free survival. So how long could we control the cancer with the drug? Then I'm going to talk about 3 phase 3 clinical trials which took the PARP inhibitor in the maintenance setting. So you had chemotherapy, you had to have a good response to it. That was defined by CT scans and often CA125 measurements. So you had to respond to the treatment, then you took the PARP inhibitor. And again, you were looking at progression-free survival. How long could you control that response with the cancer? And these are these 3 studies here, SOLO 2, ARIEL 3 and NOVA. And there are slight differences between which patients went in, which I've highlighted here. So ARIEL 3 and NOVA did not restrict just to BRCA patients, whereas SOLO 2 was restricted to patients that had BRCA mutations. And again, this is giving the drug in the maintenance setting. So you have your 6 lots of chemotherapy, and then you're trying to maintain the good response that you've had. And we're measuring the success of the drug by, again, looking at this thing which we call progression-free survival. So let's quickly look at ARIEL 2. So again, as I said, rucaparib given as a chemotherapy-sparing treatment. And you could have a BRCA mutation or not a BRCA mutation and still go into the study. In terms of what happened on the study, everybody got the drugs. There's no placebo in this because this was a treatment in itself. So everybody got rucaparib, which is taken twice a day, every day, on a sort of continuous schedule. And the sort of clever things that were done about this study were to try and identify how could you show that the non-BRCA patients responded to PARP inhibitors, and could you sort of nail it down and work out through sort of what's called biomarkers as to which women would respond better if they didn't have a BRCA mutation. And they grouped patients into these 3 groups by their BRCA status and by this marker called LOH high and low. And again, I'm not going to go into that into lots of detail. But the results of the studies, which were really, really sort of welcome and sort of landmark, were instead of giving chemotherapy, giving rucaparib to these patients that had BRCA mutations, 80 in 100 of women, so 80% of the women had a significant shrinkage of their cancers. And this lasted on average for about 12 months for patients in the study. Now, the non-BRCA mutated ovarian cancer patients also responded well to the PARP inhibitor, but their response was less. But the patients that had this LOH high measurement did a bit better than the patients that had this LOH low. And I think really what the ARIEL 2 study showed us was that rucaparib for BRCA mutated patients with platinum sensitivity is a very good treatment on its own with a high response rate. And this drug is now being compared against chemotherapy in the ARIEL 4 study for these such women. But it also gave us more interest in this idea that perhaps not having a BRCA mutation could also mean that you might respond to a PARP inhibitor. And this is something that was taken forward in the other studies. So if we go on to SOLO 2 looked at maintenance olaparib, so you have chemotherapy and then you have the PARP inhibitor as a maintenance treatment. And what it showed was that women with BRCA mutations, because this was restricted to BRCA mutated ovarian cancer, showed a significant benefit to taking the olaparib over taking the placebo in terms of the number of months that the cancer was controlled. And that's what those figures are there. The same story really was seen with ARIEL 3. So the BRCA patients that took olaparib had a significant benefit from taking the rucaparib over placebo in terms of the amount of months the cancer was controlled over being on placebo. But all patients, including the non-BRCA patients, benefited from the rucaparib. So the figures at the bottom, the 13.7 months over 5.4 months, was all patients in the study. So regardless of your BRCA status, you benefited from the maintenance PARP inhibitor. And the same thing was seen with niraparib in the NOVA trial, which you've heard a little bit about this morning. So the patients with the BRCA mutations had the most benefit, but all patients in the study, even if they didn't have a germline BRCA mutation, benefited over taking placebo. So what do these results mean? Well, for those of you with ovarian cancer, and for those of us that treat ovarian cancer, this can only mean good news. And it's very hard to pick up the newspaper at the moment and see any good news. But for all of us in the room, and as I say, for those of us treating ovarian cancer, this was very, very welcome news. And this was set against the background of a real lack of new drug approvals in ovarian cancer for many, 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 many years. And this is despite really big advances in other cancers like lung cancer, melanoma. We just didn't see this until this point of PARP inhibitors in ovarian cancer. And obviously over the last couple of years, we've had 3 new drug approvals. Now I'm going to quickly go over the drug approvals, but if you want to know the actual details, you can refer to the website of the FDA and the EMA. But olaparib has approval by the FDA and the EMA as both as a maintenance treatment and as a treatment on its own. And it also most recently has been approved for non-BRCA patients as well as BRCA patients. And that's extrapolating the data from the other trials, such as the NOVA trial and ARIEL 3 trial. Rucaparib, which is here in pink, is approved by the FDA and the EMA, and the EMA approval happened this year. And then the NOVA trial obviously resulted in the approval of niraparib, which many of you will have heard about this summer. So it was approved initially by the FDA and the EMA, and then obviously we had some really good news on the 1st of June this year, which I'll come to. So there are some key messages about these trials that I wanted to sort of summarise from myself as an oncologist, and these are really my personal opinions, but they're what's really borne out by the trial data. And I might have to move a bit closer so I can actually read my key messages. So I think what I would say is all 3 PARP inhibitors are effective as maintenance treatment, and they're effective mostly for people with BRCA mutations, but they are still effective for patients that don't have BRCA mutations over placebo. And the data is there really for niraparib and rucaparib, and the data can be extrapolated really from olaparib as well, because this is a class of drugs. If you're trying to compare the 3 trials and the numbers, I would advise you not to, because they're different trials. There's subtle differences between the patients that went into each study and how the effectiveness of treatment was measured. So I think most medical oncology would say all 3 drugs work, and I wouldn't advise any patient to switch from one to the other if you're tolerating one and you're well established on it. I think I've highlighted this thing about BRCA mutated ovarian cancer being the most responsive, but we still get the response if you don't have a BRCA mutation. The other key message is that PARP inhibitors are generally well tolerated. It's very rare. I've never stopped one for toxicity or side effects. And in the right hand with dose reductions and, really counselling women into how to take these drugs, they're very well tolerated. None of the trials showed a reduction in quality of life of the women that were on the study taking the PARP inhibitor. And there are common side effects emerging. And obviously, as we give these drugs for longer, we'll get more information about longer-term side effects. So this is the key thing. What is now the current access based on all these approvals of PARP inhibitors through the NHS? And we're hoping really that we are going to avoid any postcode lotteries, and I wouldn't say that is the case, but there are slightly different access and approvals depending on where you are currently in the UK. So if we look at olaparib, it's been available through the NHS since 2016, and the NICE approval of olaparib at the moment, we're hoping this is going to change, but is restricted to germline BRCA mutated ovarian cancer in the 3rd line setting. And in Scotland, it's the same approval, but not restricted to 3rd line, so you can give it a line earlier. If we look at niraparib, so on the 1st of June this year, I was travelling on the way to Ascot, and I think I was one of the only oncologists still in the country, because I kept being phoned by random journalists to give a comment about, what did I think of niraparib as I was trying to board a plane. But essentially, NICE have recommended that niraparib is used within the Cancer Drugs Fund. So this is not the same as a full NICE approval, which is why I think there's still an issue about it being available in Northern Ireland. And I don't know if Anna will speak to that, because I'm not involved in that, but I know that Target Ovarian Cancer are lobbying at the moment to get that sorted out. So this applies to NHS England and Wales, and obviously the SMC in Scotland have also approved niraparib. So again, it is available. The SMC approval doesn't allow patients with BRCA mutations to have niraparib because they have access to olaparib. So it's not like you can't get a PARP inhibitor, you can. And rucaparib is not yet available through the NHS because it hasn't gone fully through NICE yet. So the final bit of my talk is really to go focus on immunotherapy. And I've just really put a couple of slides in here because it's impossible to do all of this in the 20 minutes. And I think if someone says to me, what is immunotherapy and how does it work? Well, the answer back is, how long have I got? Because like I say, in the limited time that we've got, we can't cover too much. But what I would say is what we're trying to do with immunotherapy is to stop our body's immune system ignoring the cancer. So we normally have an immune system to recognise things that are foreign in our bodies, and we fight them and we kill them. And that's how we deal with, obviously, infections. And cancers are quite clever, and they've sort of tricked our immune system not to recognise them so that it leaves them alone. And what we're trying to do with immunotherapy is to sort of teach our immune system to recognise the cancer as not itself and obviously to fight it. There are lots of different strategies to do this. And again, you could fill a whole day talking about each of these strategies. And I'm really just going to focus a little bit on immune checkpoint blockade, because when my patients ask me about immunotherapy, that's normally what they're talking about, because they may have read something in the newspaper about another cancer. So immune checkpoint inhibitors work by basically allowing the cancer to evade sort of killing by T cells, which are part of our immune system. And that's because they have this interaction between these two things on the surface of the cancer cell and the surface of the T cell. If you basically block those things with drugs, so anti-PD-1, anti-PD-L1 are all immunotherapy treatments, then you sort of stop this interaction between our immune system, which is the T cell, and the cancer, which is the sort of crazy blue shape there. This then activates the cancer cell to be killed by the T cell. So we have to use these drugs to sort of block this tolerance of the cancer by our immune system. We have lots of immunotherapy treatments, immune checkpoint inhibitors, and they're listed here. And they target slightly different things within these pathways. And there are newer ones being developed, and we're involved in some of those in some of my work that we do in Newcastle. So what about the FDA approvals of these kind of drugs in cancer? So I'm going to show you the approvals for the last couple of years, and the ones for ovarian cancer are going to be highlighted in yellow. So this is 2015, this is 2016, this is 2017, and I just gave up because there were just too many to list. But as you can see, there are no yellow highlights. There is no gynecological cancer approvals for immunotherapy, apart from endometrial cancer that might harbour microsatellite instability. So for ovarian cancer, we have not got any approvals. Now, why is that? So the results of clinical trials with these sort of drugs in ovarian cancer have been quite disappointing. We've seen low response rates, although in each study that we've done, a number of patients have responded, but not very many. And there's been lots of different trials of all of these different drugs as single agents in many different settings over the last couple of years. And what's come out of these trials is the following sort of messages. Yes, there are a number of women with ovarian cancer who respond to these drugs, but who are they and how do we identify them? We actually don't know. And we're looking at things on the cancer that might help us, but also things in the surrounding cells of the cancer that might help us identify who might respond to immunotherapy. That's biomarkers. Will these treatments work better on their own, or will they work better in combination with other drugs? And that's something that we're looking at in ovarian cancer. We need more trials, but we need the right kind of trials. So trials are good if they can answer a question. And sometimes we do embark on trials and we're not going to be able to answer the question because we're trying to answer too many questions. So we need the right kind of trials to find these answers. And immune checkpoint inhibitors are becoming part of the first-line treatment of ovarian cancer through the next phase of clinical trials that are going to be done. So there will be women in the country who will be embarking on the first line of their systemic treatment for their cancer, and they may be offered immune checkpoint inhibitors as part of trials. So just to finally, the last slide really is, I was asked to talk about immunotherapy and PARP inhibitors, but there is a rationale for thinking about them both together. So there's quite a lot of sort of scientific research showing that immunotherapies or immune checkpoint inhibitors and PARP inhibitors might work well together. And the initial data is coming out of patients who have BRCA-mutated ovarian cancer and whose cancers are still thought to be sensitive to the platinum agents. And I'm just going to really show you a trial called the Mediola trial, which we're involved in Newcastle, but it's a global study being sponsored by AstraZeneca. And Mediola is a trial looking at the combination of olaparib with the PD-L1 inhibitor durvalumab. And it's looking at both of these drugs being given together. And really early results in only 32 patients. I presented the data at the American Gynecological Cancer meeting in New Orleans this year. We've shown that over 70% of women taking this combination have a response to treatment. And many of those women are having a very long and sustained response. But this is an early trial, and it's what's called an early phase study. So it needs to be proven in a greater number of patients. And the study's expanded now to look at this combination in more patients with BRCA-mutated ovarian cancer, but also to look at patients that don't have these BRCA mutations, and also to look at the combination with bevacizumab. So just in summary, I think that what I would say is that the development of PARP inhibitors has probably been the biggest development that's not a surgical development, obviously to give credit to Richard, in terms of ovarian cancer research. And we have 3 drugs, niraparib, olaparib and rucaparib, all showing a high level of efficacy in treating ovarian cancer. And as a result of that, that's many, many years of research and many women who've obviously volunteered to take part in all of these clinical trials, of which we're very thankful. The greatest benefit is, as I say, still seen in women with BRCA mutations, and at the moment the approval and the access to the NHS is as a maintenance treatment. I would say that which one should you take? It's the one I can prescribe. That's what I say to most patients. I would say they're all, showing promise in all 3 trials. There's subtle differences between their side effects, but for those of us limited to what we can prescribe through the NHS, which PARP inhibitor would I prescribe? It's the one that I can prescribe. They're very well tolerated, and many of you might be on PARP inhibitors. I know people that are, and as women take them for years and years, we may learn more about their longer term side effects, but short term side effects, they're very well tolerated. In terms of what's happening next, well, we know that SOLO-1, which is a trial giving PARP inhibitors the first line of treatment, is going to report this year. And it may be that PARP inhibitors move as part of standard of care at the very beginning of treatment, so following that initial line of chemotherapy when you're trying to treat the cancer in the curative setting. Combinations are coming as well, and there'll be lots of trials that are coming up. And immunotherapy, what I would say is watch this space, and we're really not there yet in ovarian cancer. And many of these trials, things you hear about in the newspapers, they're often the results of very early studies involving a small number of patients. So we really don't know yet where we're going with immunotherapy. And this is Newcastle at the height of the Great Exhibition of the North. So many of you may have come or may not have come. I personally moved to Newcastle to the horror of my family based in London because I didn't know where it was. But obviously they enjoy visiting us, and you're always welcome. And I'll welcome any questions from the panel after. Okay.